Hello, I'm Nick Rainey, and I'm a physical therapist student at Rocky Mountain University of Health Professions. This is my capstone presentation that I am presenting, and my anticipated graduation is actually 3 days from now, December 13th, 2013. So my patient, he was a 64-year-old male with chief complaint of left shoulder pain. A little bit of history about him. He is a retired middle school history teacher. He's married and is about 5'7", and BMI is pretty average near about 25. Has quite a bit of a history with other systems. He has a history of liver transplant, gallbladder removal, and appendix removal, and Crohn's disease. He has a PICC line in his right arm to prevent the need for undergoing dialysis. And that's in his right arm. Remember, he's coming in there for left shoulder pain, so while it's something to think about, it's not on the involved shoulder that we're looking at. Did take a lot of medications. I discussed these with him, not all of them in detail. I want to make sure a pharmacist is looking at them because while I have a little bit of pharmacology background, somebody who is a doctor in pharmacology is going to be much more qualified than I am. And he said that he does discuss it with them, so they are being looked at. Anytime I see somebody with a lot of medications, I like to make sure that somebody is looking at them, making sure that they're all appropriate. So that my patient was here because of left shoulder pain again. It was insidious onset. It had been present for about 2 to 3 weeks. He just didn't know why it happened. It reached about a 6 of 10 on the numeric pain rating scale at worst, and achieves a 0 of 10 at best. The pain is affecting his ability to put on a shirt and take off a shirt in a timely manner and without pain. He can do it on his own, but it just takes him a little while. He's also a volunteer at where he works on restoring a railroad car at a local museum. He's unable to do this, which is frustrating for him. He was referred to us by a diagnosis of rotator cuff tendonitis. The referring physician is a fellowship trained in surgery in the upper extremity, and he requested modalities: active range of motion, passive range of motion, stretching, home program, therapeutic exercise. I never discussed with the referring physician some of those details. It seemed to me that, obviously the orthopedic physician knows a lot about the shoulder if he's fellowship trained and everything, but I think basically knew that he wasn't going to perform surgery, so sent us to figure out what was going on and checked off a few of the things on the referral sheet of what he wanted done, but basically left it up to us to what we wanted to do. At least that's how I took it. Looking at other systems, I know we discussed some of the history that he has, but more so what I was doing here is see what would be involving, or affecting his prognosis with us. Cardiopulmonary, I made sure that, I always want to make sure it's not cardiac based. You have that, left shoulder pain. Make sure that it's not due to ischemia or myocardial infarction. He denied that physical exertion increases left shoulder pain. I did have him take off his shirt. I wanted to make sure I had a good view of the area. Nothing on his skin made me think that was causing the shoulder pain. Neuromuscular, everything was within normal limits. I tested his sensation with light touch, not moving, just both fingers on both sides, see if it was same or different on each side. Then I also tested monosynaptic reflex, also known as deep tendon reflex. I think monosynaptic reflex is a little bit more correct of a term. C5, C6, and C7. They were all 2+, very normal. And he denies pain in his upper back, thoracic region, neck, cervical spine, elbow, wrist, and hand. I would like to make sure I know if there's anything else that's going on that I should be aware of. Tests and measures. We looked functionally. That's what he cares about. And doffing and donning a shirt, like I mentioned earlier, was painful and it took increased time. And I could see that when I had him take off his shirt so I could observe his integumentary system. Structurally, just looking at him sitting there on the mat table, his left shoulder was visibly higher than his right shoulder. That could be for a variety of reasons. I don't normally look too deeply into that, but it's something I like to just know, so I know my overall patient better. And he had a bit of a visibly distorted torso due to all the visceral surgeries. Nothing major, but just a little bit, something to note. Active range of motion and passive range of motion with overpressure in the thoracic spine and cervical spine were within normal limits. They didn't cause any pain. I looked at the SC and AC joints, and they were painful to mobilize. The AC joint was a little bit hypermobile. It wasn't stuck, but it just wasn't quite right, I guess. I'm sorry, a hypermobile. Obviously, it wasn't stuck. It moved. It wasn't loosey-goosey type of thing, but it moved more than I would normally want to see on the AC joint move. And palpation, I didn't perform palpation, and as you'll see later, I probably should have. So for tests and measures, I like to put a little graph here so you can see it. The problem with this, it doesn't show what the pain levels were, and that is important for him, as I'll show you on the next slide. All these are measured with a goniometer, and they were measured in degrees. The active ranges of motion were performed in sitting, and the passive range of motion were performed in supine. As you can see, the blue or the right arm, that was the non-affected arm. He did have the PICC line, but he didn't complain of any pain there. And he had very good range of motion. Active range of motion, passive range of motion, and flexion were both 180. And abduction, it was a little bit more active than passive. I think it was just the positioning of the seated to supine. Nothing really to note there, though. But it very, very good there. So I have reason to believe that his left shoulder should be up there, and his left shoulder was definitely not. Active was more than passive on the left shoulder in flexion, and the same thing with abduction, which could seem very interesting, but I don't think it's as interesting as it may seem, just due to, if you look over on I put the pain ratings between passive and active, and they're both more painful actively than passively. And I think that's just due to whenever I'm moving him, I'm more apt to stop when they start mentioning pain, because I don't want to be the cause of their pain, particularly on initial evaluation when they're still seeing if they trust me or not. And so that's why I think that the ranges were less passively than actively. Then I also did special tests. I did want to make sure cervical radiculopathy was not involved, and so I looked at Weiner had a clinical prediction rule or a test item cluster to look at that. And so we looked at Sperling's distraction, upper limb tension test A, sometimes described as 1. That article is A though. And cervical rotation. All of those were negative, and so it gave me a negative likelihood ratio of 0.23. Problem is with the negative likelihood ratio, it's pretty broad. 0.06 to 0.85 is the 95% confidence interval, but it did give me, I don't, just at face value, it'd be pretty hard to have a cervical radiculopathy and not have pain with any of those. Then I also wanted to look at subacromial impingement syndrome. You can see the 5 tests that I used for that. Michener et al. Looked at these tests with impingement and said there's a positive likelihood ratio of 2.93, and it went 1.6 to 5.36 if 3 of the 5 were positive. As you can see, the 3 of my 5 were positive. The Hawkins-Kennedy, empty cannon, NIRS were painful. Resisted external rotation and painful arc were not. And then I also wanted to look at AC joint arthritis, so we looked at cross-body adduction. And that was painful, according to Gia. I think I'm saying that right, JIA. That gives you a positive likelihood ratio of 3.67. I couldn't get the confidence interval on that one, though. So on my evaluation, I had the primary activity limitations, according to looking at this more of an international classification system of functions viewpoint. I put donning a shirt and raising his arm in the air, the primary activity limitation. If he could do those things, I think he could do everything else that he needed to, and those are those day-to-day things that were very much problems. Participation restriction, biggest one, was working on a railroad car restoration. He wants to get back to that. He really enjoys that, and that's what he needs to get back to, and he's not able to do it. The impairments are range of motion and pain. I don't think strength is a problem, but the primary impairment was range of motion. So I look back on my decision making. I used an evidence-based examination. I don't normally group my tests according to sensitivity and specificity. I normally perform them based on the position of the patient. And I do that for two reasons. One, just for ease of working with the patients. They don't have to stand up, lie down, sit up, turn. But it's also, there rarely is one test very sensitive or very specific. Normally it's more test item clusters that I look at. So I normally perform them, according to where the patient is positioned, and then I'll evaluate them later to see, okay, even if I thought it was one thing, if I'm looking at my diagnostic values, they seem poor, or very strong, that tells me a lot. So normally just go evaluate it at the end. It doesn't really guide it on this was sensitive, then I go perform this sensitive test, and I go to this specific test and this specific test. And partly, like I said, because not rarely are they, I can't think of any, at least with the shoulder, that are that specific. And also partly then there's more thinking during the exam. I'd rather just be pretty efficient, pretty quick, make sure I'm not missing anything, and then go and evaluate afterwards. You might notice I didn't use labral tests. And I honestly, I do vacillate back and forth with how important these are. With critical appraisal of a topic that I did recently was on labral tests, and they had experts doing them. And they looked back and forth at what was positive and what was negative, and they couldn't agree. It was poor reliability. And if the experts are doing it on the same patients and they can't agree, then I didn't think that I would have any chance of doing that. So I normally look at it as a diagnosis of exclusion, and if I'm not making the gains that I think I should be making. So I didn't do any labral tests. I didn't think it would tell me more than I already had. And then also, the reason I made that diagnosis, I felt like I reached treatment threshold. I don't need to understand everything about a patient's condition before I start treating them. All I need to know that first they're appropriate to be treated by a physical therapist. If it's a cardiac condition, I don't need to be working on their shoulder. But or if it's a liver condition or something else going on or a tumor, I felt like it was musculoskeletal. I felt like I could start to make changes. As you can see, I'll discuss some of that later. So for my diagnosis, I put that yes, he did have a clearly identifiable health condition. Range of motion. Here I'm going to be going over some pathoanatomical, some international classification of function. Range of motion, I've added the primary impairment that needs to be addressed. If he can get full range, I think he'll be all right. And that'll allow me to address his primary functional activity limitation of putting his shirt on and his primary participation restriction of working on a railroad car. He's able to do all those things, he'll be a happy man. Differential diagnosis originally included cervical radiculopathy, impingement/rotator cuff involvement, complete rotator cuff tear, and labral involvement. I don't really separate out between rotator cuff tear and subacromial impingement syndrome, mostly because there's no really way to know clinically, and I don't think it matters. It doesn't really change treatment. It may change prognosis a little bit, but if there's enough impingement, then the rotator cuff will tear. But we do have research, though, that even with people with complete rotator cuff tears don't have any pain. Typically, those people are above 60, which my patient was. So it didn't really matter to me if he had a rotator cuff tear or not. I was going to treat it pretty similarly. But as a complete rotator cuff tear, while some people don't have pain, I do want to look at that. I diagnosed that due to the positive likelihood ratio that I discussed with the Michener article earlier, and it gave me a specificity of 74%. I'm going to stop right there, and we're going to do the rest in video 2, so we'll start with the critical reflection part of this.